The article by Batchelder and colleagues is very timely. Let me give some background here. When adalimumab was tested for psoriasis, it was first tested in Europe, and there were actually a fair number of cases of reactivation of TB. Now, TB, of course, is endemic in Europe and not nearly so much in the United States. But when they did the testing in the United States, they decided before administering adalimumab to test everyone for TB. And if they tested positive, they were given TB prophylaxis for latent TB in order that they not see those cases of active tuberculosis. And sure enough, the number of cases of reactivation of TB plummeted in the US. So when it was approved in the US, in the label, they were told that everyone needed to get TB testing before and periodically thereafter. And in many places, it's been traditional to test for TB once a year. The next class of drugs after TNF blockers to be approved for psoriasis were the IL-12/23 blockers, and namely ustekinumab. And ustekinumab is based on an antibody to IL-40. And it turns out that there are people who are born deficient in IL-40. And the main problem they have is that they are prone to mycobacterial infections like TB. And so when ustekinumab was approved, it also was given in the label that TB testing has to be done before administering the drug and periodically thereafter. Now, the same thinking was applied to the IL-23 blockers because those patients might also be prone to mycobacterial infections if the IL-12/23 patients were. So it's understandable why they should be getting the TB testing as a requirement. But I must say there has not been an increase in tuberculosis in patients on ustekinumab or on the IL-23 blockers. But this article becomes even more timely for the IL-17 blockers. So the people who are born deficient in IL-17 only get yeast infections. They do not get mycobacterial infections, yet in each of their labels, it states also that they should be subjected to the same TB testing before and then periodically thereafter. And it does not really make sense that that be the case, but most of us have actually observed that and follow the guidelines so that we do check for TB before administering IL-17 drugs. This article points to the cost of testing for TB, and specifically the blood testing, which is an interferon-based test result, unlike the old skin testing that is still being done about a quarter of the time. So the point is, there's a cost associated with it. There's no evidence that IL-17 blockers increase TB. And actually, despite the background risk in IL-23 or IL-12/23 blockers, there has not been an increase in tuberculosis. So the article raises an appropriate question, which is, shouldn't we be thinking about the cost of these tests if we're administering them to patients, knowing that there's very little risk that they'll get tuberculosis? That's still an unanswered question. The package inserts still call for TB testing, so we are still doing it, but some of my colleagues have stopped repeating annual TB testing in patients on IL-17 blockers specifically. And that might be a take-home message for our audience. So with that very nicely done article, which shows the costs of TB testing and the low rate of positivity discovered by that TB testing. Thank you very much.